everyone. So, great. I'm glad everyone could join us this evening, either here or join us virtually. Welcome, everyone. I'm Nancy Miller, and I'm a professor and the director of the School of Public Policy. And on behalf of the School of Public Policy and the University of Maryland, Baltimore County, I'd like to welcome you to our 10th annual Judith A. Shinogle Award Lecture. This award was established by the family of Dr. Shinogle to recognize a student whose research exemplifies the scholarly rigor and the health policy focus of Judy's work. Judy, when she was with us, was a former senior research scientist with the Maryland Institute for Policy Analysis and Research. And she was also an adjunct associate professor in the School of Public Policy until her untimely death in May of 2012. Judy's work for MIPAR included studies on childhood obesity, wellness initiatives, and gambling. So this afternoon, we're really pleased to have Judy's sister, Dr. Mary L. Cohen, with us, as well as Judy's friend, Jim McCarthy, and three of Judy's friends and colleagues, Drs. Hayden Huskup, Pinka Chattery, and Marissa Domino, who are all joining us virtually. And they're going to join us and share their memories of Judy. That will be followed by Dr. Zoe McLaren, who's an associate professor in public policy, and she will introduce this year's award recipient, Mr. Mark Boward. So let me say just a few words about Mary L. Cohen, Judy's sister. So Mary is Judy Shinogle's younger sister. She's an associate professor of music education at the University of Iowa. She researches music making and well-being, songwriting, and collaborative communities. Along with her co-author Stuart Paul Duncan, they're completing music making in U.S. prisons, listening, which is actually completed. So I didn't get it. I didn't get my. Yay! Oh, so I'm not too far behind. No, yay! So it's here, right? So it just came out from the Wilfrid Laurier University Press. She's also collaborating on international initiatives to explore research on music making in prisons and peace building, including an upcoming keynote. So I'm certain this has occurred as well. So her research has been published in the International Journal of Research in Choral Singing, the Journal of Research in Music Education, the Australian Journal of Music Education, the Journal of Historical Research in Music Education, Journal of Correctional Education, the International Journal of Community Music, the Prison Service Journal, the International Journal of Music Education, and she also has numerous book chapters. So please join me in welcoming Judy's sister, Mary Cohen, who will speak with us.
Thank you, Nancy, and congratulations to Mark on the award this year. We're very happy. Big thank you to my husband, Matt Cohen. We are just so grateful that we could be here in person. Thank you for scheduling it this week. We're in town because I have a conference in National Harbor, the National Music Education Conference. We haven't met in person since 2018, so we were able to be here in person to celebrate Mark and to honor Judy. So as Nancy mentioned, I'm the youngest of I shouldn't tell all the details, but I'm the youngest of 6 siblings with a pretty big spread in age. My oldest sister, Linda, is connecting from a distance with my mom in Wichita, Kansas. Linda's 16 years older than me. So quite a big spread with 6 children. I used to think it's a year apart, a year apart, a year apart, 5 years, and then me. I thought I was a mistake. And Mom said that I was actually a bonus prize, which made me feel much better as far as it goes. A big thank you to Miriam Ralston for all her work coordinating this, to all the UMBC faculty, staff, students, to all of you for being here, all the past winners of this award. Now we have 10 people that have been honored with the Judy Shinogle Scholarship Award, so our family is really grateful that we can support you. Also, thank you to everybody who's connected via the live stream today. So, couple brief stories about Judy. She was an amazing teacher. And for me, growing up, she taught me how to drive stick shift. Can you believe that? She was going to go on not a holiday, she had a summer study abroad in Spain. So I was going to be able to drive her blue, it was one of those blue Toyota station wagons that was stick shift. And the first day she took me out to drive, it was an afternoon, and for some reason I was really tired, and we were driving, she was driving to take us where we were going, and I started to fall asleep. And she's like, okay, Mary, we're not doing this today. We're going back home. Because I was like, she knew it was not wise to teach someone who was falling asleep, which if you don't know the actual story of how she died, it was because someone was drowsy. On the Baltimore-Washington Parkway, we just came from this road. It was 6 a.m. on May 20th of 2012. She was taking her two German short-haired pointers, Siegfried and Brunhilde, to an agility trial. And she was driving 6 a.m. east. The sun blinded her view of a man who had fallen asleep at the wheel and hit her head on. So that is actually what happened. Bruni died in the accident. Siegfried survived, but he just died last year. And that death of the dog was really, I had no idea how hard that would be. Judy also was very creative and fun. As a child, my mom would make us Halloween costumes. And one year, Judy dressed up as Snoopy and I was Woodstock. And we would go around our neighborhood and trick or treat, and one lady goes, oh, how cute. It's a ghost and his brother. So that's always a fun joke to have. When Judy finished her master's from Harvard in public health, I got to travel with my mom and my dad, and we celebrated after her graduation. It happened to be like Dairy Appreciation Month, and they had a big thing called a Scooper Bowl in Boston. Have you ever heard of it? Mm-hmm. It's a celebration of ice cream, and it's huge. You pay one fee, and you have this huge tent of vendors, and we love ice cream. So we decided, first we'd get the cup and we try all these new flavors, and then we decided, let's try every single vendor we can find. We get one cup, I take a bite, she took a bite, and then, then after that whole afternoon of ice cream, we went to the Cheers bar. I don't know how our bodies handled that, but it was quite a lot of fun. In fact, in a moment, you're going to see a video I made, and you'll see an image of me and my mom and Judy in front of the Cheers bar. And now you'll have a memory of, or a story of, that was post Scooper Bowl, ice cream Scooper Bowl. So also, then after what happened in May of 2012, it was the first time I'd ever experienced grief from someone close to me. I'd been honored in a life without having family members die, and I didn't know how unexpected death was really, really hard to navigate. I collected a big list of books about life after death, trying to make sense of it all. A number of Judy's friends had a celebration of her life the week after the car accident, and they gave away the bracelets. I still have one. We used to have two, but one of them broke. They ripped apart. The bracelet on one end of the bracelet says, WW Judy D. What would Judy do? And the answer was, find the joy. She was always having fun. So I used that line and wrote a song in my own grieving process of how do you find joy when you are dealing with grief? There's been so much grief in our world these past 2 years. And at the time, for 12 years before the pandemic, I led a choir in a prison in Iowa. So I wrote the song, I taught the men and women. The choir's made of people in prison and people from the community who sing in the prison with the men. Oakdale Community Choir. And we learned the song and performed it at the May of 2013 concert themed Mourning is Broken. M-O-U-R-N-I-N-G. Mourning is Broken. So the process of learning the song was really, really, really powerful for me to be reflecting on what in the world are we doing in these bodies? What is the purpose of life? As we're learning the song, you can imagine the title, Find the Joy. There's lyrics, how do we find the joy when we're dealing with grief? And on the walk out of the prison, one of the outside volunteer choir members named Kevin Coomer said to me, Mary, you know what? He said, your song is really great. I like it a lot. It's about trying to find joy. But for him, he said, joy is actually, in my opinion, he said, is always within. It's simply a matter of pausing to feel joy. And I'm like, of course, I learned that growing up from different wise people, and I just hadn't made that deep connection. So after I heard that point, we changed the end of the song, because it used to say, how do we find the joy, find the joy. At the very end of the song, it says, we pause to feel the joy. So I invite us to reflect on that idea as it makes sense to you, and enjoy a video that I put together. And the video has a number of images of Judy, of our family. It has images of past winners. I hope that all of them are there. It's a recording of the Oakdale Prison Choir doing the song back in May of 2013. And at the end of the whole video, the song is over, there's applause, and then there are still images for a little bit. So as that happens without any audio to keep your focus, I invite you just to allow the message of the song, the lyrics, the melody to just settle into yourself in a way that makes sense for you, just to settle. So anyway, thank you. And if anybody is interested in this book, I do have a QR code you can order at a discount. I'm happy to give you that later. So we'll take a big breath in, a big exhale, and then repeat that as much as you need to if that's helpful. This is the first time I've ever done one of these videos, so bear with any little glitches that might happen with the lyrics or the visual names underneath. Hopefully it'll play.
So I'm going to request Dean Boward, I know you're trying to annotate this. Can I have you not? See if that lets it play. Sorry.
Technology is not always friendly.
Okay, apologies. Let's try this again.
It's my mom and my mom's mom. Next, Jim McCarthy.
All right, ready? I didn't know there was. As Mary, my name is Jim McCarthy, and when I come back to UMBC, I do this. I always take a walk around the fourth floor of a Public Policy building and just kind of see who's there. And I was there. We went through today, so gone are like Don Norris and Dr. Saul Keever and Linda, and there's a lot of other staff. There's been a lot of changes here in these last 10 years. I know when I was talking to somebody here, it's like, well, we're still like virtual still here. The school really is in a hybrid mode. We're not really back to, what it was type of thing. But it was, it's been a couple of years, but it was a good thing to do. A lot has changed though. Even walking around this place, quite a bit has changed. So it's, that's all for the good, I think. I happened to meet Judy in 1990 when she came to DC, and she was working for APHA and graduated from Kansas with her PharmD. Judy was really good at school, and she only got one B, and it was in golf. And I think we still have her golf club somewhere, because Shinogle's never threw anything out. Nothing at all. I mean, remember one time, Judy, I think, was away at Harvard, and all of a sudden I get this huge box in the mail from her mother, and it was just like a bunch of crap, all that stuff, and, sixth grade stuff, report cards, all that type of stuff just kind of like shows up. So that was always the way things were. When she started working for APHA, she decided that really she wasn't happy carrying out other people's policies or implementing them. That if you don't have a doctorate or at least 10 years and like a master's of working for a place, affecting policy doesn't really happen that fast. So she wasn't happy with that, and she actually came and took a course here at UMBC at night in health policy and decided that she liked it. And so she decided, we picked out two schools, which was Penn and Harvard, and if she got into either one of those, then she would go in that direction. If it wasn't, then it wasn't really meant to be, and she would continue to work at APHA doing those type of things. She got into Harvard and packed her up and off she went. So, which is where she started there, and she started working for basically, besides her stuff, she worked for two professors, Dr. Newhouse and Dr. Chow. And I think that's how she met Hayden, was through working for Dr. Newhouse. When she worked at CBO, which happened a little later on in the summers, when she would come back to DC and she'd work at the Congressional Budget Office, she would score prescription drug stuff. And she was there one time, and she'd only been, there was like this big conference, so everybody had to show up at CBO. And one of the speakers was Dr. Newhouse. And when he was leaving, he saw Judy, went over and talked to her. And everybody was like, how did you ever know him? That was, you've only been here and that type of stuff. And so she was very lucky to have worked with some very wonderful people while she was at Harvard. And from there, she went to Hopkins. And Hopkins is where she met Marissa and Pinka, because they were like about a half a year or a year ahead of her in getting their dissertations. So they were taking the same type of classes. I do have a Pinka story, though, because one day I'm home and Judy comes home and says, you're not going to believe this. There was one of the professors was talking about some economic principle from a professor from Chicago. And in the middle of this whole thing, Pinka stops him and says, I was at Chicago and I know the professor, and that's not what he meant by what he was saying. And she was so thrilled that somebody actually would, say something like that, that she was like, I gotta meet this person. So she and Pinka and Marissa and Dr. Salkever, who was her professor, made it through. We used to watch Dr. Salkever's dog, Kirby. He and Mary had this English setter that was kind of strange, so nobody would watch him. So we always got that job. It was a great time. So after Hopkins, it was because of these type of situations. Money is a big thing when you're trying to get a dissertation, because it's basically all on loans. And so at that time, Harvard said, you got to start paying us. So luckily, she was able, the University of South Carolina knew her from her prescription working for APHA. So they hired her, even though she hadn't got her dissertation. She had passed everything and everything else, but she hadn't graduated yet. So for those 4 months, so she went to South Carolina and really liked it down there and had a great time. But then there's two schools in South Carolina. Like there was two prescription drug schools, two medical schools and everything. And at the time, they tried to put them both together. And when they did that, whoever they picked to run the whole thing, nobody in Judy's department liked, and the whole department retired. They were all been there for a while, but the whole department, that was it. So she was like the one other person was there. And they didn't have any department chair or anything, and it was like, it's time to go. So she came up to University of Maryland, and on her first day at the job, she's got all of her stuff in her car, and she pulls up by the door to move her stuff into Maryland. And this guy comes out yelling and screaming at her, says, you're parking in my parking space. There's nothing there that says that it was. And that was Gary Williams, who was the basketball coach for University of Maryland, right before they won like the NCAAs that year type of thing. So needless to say that she never was a big basketball fan. She was a Kansas basketball fan anyways, and that was never going to change. But Maryland just didn't work for her as far as a place goes and where they were and their whole thing. And so she decided to take a soft position here, soft money position here, and see if that wouldn't work out. And as soon as she got here, she just loved it. She loved the people, the place, everything just clicked for her. She started applying for grants and was very successful in the grant stuff. Her largest one was her NIH grant that Dr. Salkever had to stay here for a couple more years just to help finish that off, I think, at the time. But it was, she really liked doing that type of stuff. She enjoyed the flexibility it gave her. She was also involved with Pinkett, like in ISPOR and other organizations. They used to travel all over the place talking about those things, as far as those type of thing goes. But she was always a stickler for Mark here. Her numbers mattered. Sloppy math wasn't anything that she had any tolerance for. And when she used to review people's papers and stuff like that for these various conferences and stuff, if you didn't meet her standard, you were in trouble. So she really had a lot of respect for people that didn't just kind of go fuzzy on the math part of the whole thing. When she went to South Carolina, decided she needed a dog because she hadn't had a dog since she was like 12 or something like that. So she got a dog, Bruni, figured she'd have with her when she was in South Carolina, and she got onto agility trials, which are these things where you run around with your dog and you go teeter-totters and weave poles and everything. And she absolutely loved it. You can actually go on YouTube and you put her name in with one of her dogs and you'll see where she's at these various events. And I used to call them the doggy people, but she used to go hang out with these people on the weekends, and there'd be like 15 or 20 group of women that would sit there in like chairs like this, and they'd watch one of them go through these whole things, these large events. And every weekend was another one. And a number of those people have come here, the doggy people. I know Stephanie been here once or twice, but there's been a bunch of others that have done those type of things. And she again got another dog, Ziggy, and so she had two dogs, was doing 2 trials, and that's basically the type of stuff that she did. She really enjoyed that type of stuff. But so when Judy unfortunately had this accident and died, the one thing was that we all remembered was how difficult it is, no matter what type of relationship or what your background, people helping you are, it's really tough going from master's to get your doctoral dissertation. It's kind of a tough road. And so that was why this scholarship is supposed to be, in some ways, a help. And as far as this particular event, I think is very helpful, where people get to be able to talk about what ideas, give them that they're passionate about, enough to do all this work and go through all this torture to be able to produce this thing. And so that's why this particular scholarship was. And the people here have been wonderful at UMBC as far as helping us every year be able to put this together. This is much different than all the other ones, but since we're coming back from their 3 years of not doing these, it's plus we all this new technology. It's actually quite interesting, and I think that we can continue to do things like this. I think this might work actually better. So thank you again for allowing me this opportunity to come.
Thanks, Jim. And so next we're going to hear from a friend and colleague that Jim mentioned. First, we're going to hear from Dr. Hayden Huskamp, who's joining us virtually. Welcome.
Oh, thank you so much. Can everyone hear me okay?
Yes.
Yes.
Oh, terrific. Thank you so much for inviting me to be here today. It's so wonderful that I was so happy to watch that video and see those photos of Judy and hear the beautiful song. It's just so nice to be able to share memories of Judy with other people who really cared about her. I met Judy in 1992 when she was finishing, I think Jim sort of talked about some of this, when she was finishing her master's program at Harvard School of Public Health, and right before she went further south to Hopkins for her PhD in health economics. At the time, I had just started a PhD program myself, and we were taking some classes together. And I felt completely overwhelmed in my classes that fall. I'd been out of school a few years. My math was more than a little rusty. And I felt underprepared for the classes I was taking and just, was really struggling. And I met Judy, and she was a huge bright spot in that year for me. First of all, I learned a ton from Judy. I think Jim already mentioned that she's, math was just sort of seemed to come naturally to her. She was really smart and really good at figuring out some of the challenging economics and math material we were being presented with. And she had a really logical way of working through a problem on a problem set and really excellent quantitative reasoning and statistical skills. But more importantly, Judy just didn't seem to let things with school get her down. She had this amazing attitude. She wanted to solve the problems in the problem sets, and she would work extremely hard to do so. But she also wasn't going to let it spoil her day if she couldn't get something. She had this great perspective, even back then, even at that point in her career. She seemed to understand the importance of balance in her life. Judy was passionate about her schoolwork and certainly about the research she went on to do throughout her career. She loved health economics and conducting research that could improve the care people received and improve the way that the healthcare system functioned as a whole. And she was a phenomenal researcher. But she had a lot of other passions as well, and we've heard about some of those. And she was committed to spending time with the people she cared about and doing things that she loved outside of work also. For me, Judy was total sunshine, always laughing, always making other people laugh. She was always helping and supporting other people. When you were feeling challenged or overwhelmed or sad, whatever, Judy was the person to go to, and she would always make you feel better. And you knew whenever you would get together with her that you were going to have fun, because there just was no way around it. Every time I think of Judy, in every memory I have of her, she is smiling and laughing, and she's making me do it too. So it's so wonderful to think about her and to think about those times that I had with her. I was thrilled to read the bio about this year's Shinogle awardee, Mark Boward. Judy would have loved your work, Mark. The term big data wasn't really used at the time, and machine learning wasn't really a thing in health services and policy research. But Judy was a data science nerd in the best possible use of that phrase. And she would have loved the work that you do. So I want to congratulate Mark on this honor and just say that I'm really happy to be able to be here to help celebrate this award and to share a little bit about Judy and how she approached both her professional and personal life in the hopes that more of Judy will rub off on me and on all of us. So thank you.
Thank you, Hayden, for your sharing your memories and of Judy. And we'll next hear from another friend and colleague, Dr. Pinkett Chattery.
Can everybody hear me?
Yes, Pinka.
Hi, I'm very happy to be here sharing memories of my friendship with Judy and Judy. And I actually really enjoyed the comments that people have made so far, because I remembered so many things about her, actually. A lot of my experiences were linked to these experiences. So Judy was one of my closest friends in graduate school. We lived together for a month when we were studying for our comprehensive exams. We traveled together to England for the IHEA conference. It was one of the first ones in York, England. We took classes together. We studied together. We shared many restaurant meals. We used to go to Lido's in Baltimore. Long conversations, usually when she was trying to calm me down when I was stressed about something and she was trying to get me to be more realistic and practical about things. And honestly, after 10 years, I still really don't believe she's gone. I mean, I feel like I just haven't seen her in a long time. I think of her all the time. She impacted my life in many ways, but most of all, she taught me not to take life so seriously. I've always been very serious and intense, and Judy was a wonderful influence on me. She valued being fun. She valued being spontaneous. She valued friendship. As you've been hearing, she was a serious scholar and a serious student, but she always knew what was truly important in life: relationships, fun, living every day, and spontaneously not dragging yourself through a schedule every day. Some of Jim's comments made me remember a funny story. We went to the Academy Health Conference together, and I guess I'd been eating a lot of chocolate or something because my suit didn't fit me. So when we got there, I realized I needed a new suit. And so I made the mistake of taking Judy as the babysitter for my 2-year-old son to the mall. And Judy was supposed to watch him, he's 2 years old, and I was supposed to get my suit. And every time I'd come out of the dressing room, Judy would be running around she was chasing him around the store. And she was having like a great time, and my son was laughing his head off. And I was actually sort of mad at her at the moment, but it's such a precious memory now because I think about her in this. I was so stressed and in this very ridiculous situation. She was having the best time of her life chasing him around. So I learned a lot from having Judy in my life. I learned not to take the less important things so seriously. She always talked about her family. I don't know if her family knows that, but especially Mary, she talked about a lot. Her mom, every time I'd say, "Oh, Judy, I like your sweater," she'd be like, "My mom made this," and she'd kind of smile. Her mom used to make her a lot of clothes, and Judy would always tell me about her mom. Judy was not a judgmental person at all, and usually when I was being crazy, she would just kind of look at me and smile until I calmed down. She wasn't somebody who gave people unwanted advice. She lived her life her own way, and I'm so glad that she did. I hope her family and her friends know that I always think of her. I always cherish her memory. Sometimes she just pops into my head for no reason, and I think about things that we used to do. And I'm very happy that this award is helping so many PhD students. Judy would have wanted it that way. And I wish Mark the very best as he receives this award. Thank you.
Thank you, Pinka. Next, we're going to hear from another friend and colleague, Marissa Domino.
Good afternoon, everybody. This is Marisa Domino. I'm joining from Phoenix, Arizona. I'm so sorry I can't be there with you in person, but I'm grateful to UMBC for hosting this award event, especially this year on the 10th anniversary of her passing, and grateful to be among so many of you that respected and loved Judy. I was a classmate of Judy from the PhD program at Johns Hopkins, just like Pinka was. And like Hayden and Pinka, I have very fond memories of being a graduate student with Judy. As you've heard from everybody today, and we'll always hear from everybody, she was that rare combination of very smart and very fun, and always seemed to make time to do the things she loved. But tonight my task is to talk to you about her research areas and contributions, which were also very meaningful. Judy's work spanned a number of areas, but barriers to good health and good health care and empathy to those who experience those barriers were a constant throughout her work. One of the topics Judy and her many collaborators wrote about was obesity and physical activity, inspired by her own interest in exercise, and she was very inspirational in that regard. Judy's work examined the factors that are associated with obesity, especially in rural areas, and characteristics of people who underwent gastric bypass surgery. Judy and her collaborators examined the economic costs of obesity in children, estimating the lifelong complications that can be associated with being overweight as a child. Another one of Judy's research interests was a series of papers in collaboration with her and my own advisor and mentor, David Salkever, who was mentioned also before. Judy and David, along with several other esteemed collaborators, conducted research on disability insurance. They asked important questions about what created higher disability claims for some employed people than others, and whether mental health treatments affected the use of disability claims. And probably most relevant for today's awardee was Judy's interest in health policy generally and medication adherence specifically. Judy was not content to use her considerable methodologic skills just to estimate the effect of medication on various types of health, which is still an important area of research. But her work in this area really demonstrated a curiosity about how people interact with the whole culture of medications. She tried to understand medication adherence as an economist, looking not just at incentives for taking medication, but also the effect that medication themselves could have on patient preferences and perspectives. She also examined the interaction between other social service programs and financial barriers to accessing medications. And finally, she and Hayden wrote about the then impending Medicare Part D program and its limited ability to control medication costs. And I'm sure Judy would be smiling today to know that she and Hayden were exactly right, that new legislation was only passed this year and only a few months ago that finally allows Medicare to negotiate for drug prices. This interest in Medicare policy is a common area of interest Judy shared with today's awardees. So on that note, I will turn the mic back over to Miriam. Thank you.
Thank you, Marissa. And so now I'm going to acknowledge and introduce Dr. Zoe McLaren, who's an associate professor in the School of Public Policy. She's the mentor and chair of this year's award recipient, Mark Boward, and she is going to introduce Mark for us.
Mark Boward has over 20 years of healthcare research and policy advisory experience, specializing in big data analytics, statistical modeling, machine learning, and statistical analysis. His current work as a senior lead scientist at Booz Allen Hamilton primarily focuses on projects with the Centers for Medicare and Medicaid Services. His responsibilities include the design and creation of complex data warehouses used to monitor and evaluate the providers participating in the CMS's Innovation Center. Prior to his current employment at Booz Allen, Mark worked and managed a variety of analytic, research, and development teams at Deloitte, Impact, Magellan Health Services, and Impact Team. While working at Deloitte, Mark managed the advanced analytics and ad hoc analyses activities for the Centers for Medicare and Medicaid Services Risk Adjustment Data Validation Project. This included leading a team of data scientists to implement advanced visualization, machine learning, and natural language processing. The team developed data models responsible for detecting and alerting potential fraud cases to CMS. He has a master's degree in psychology from Andrews University and has reached the candidacy stage in our Public Policy Ph.D. program. So without further ado, Mark, the floor is yours.
Apologies again, everybody. As you can tell, this is a big learning curve for us. So,
Okay.
is that okay?
Yeah.
Are you sure? Yeah, right? Okay. So slideshow.
Thank you. Hello, all. I'd like to begin with a huge thank you to the Shinogle family. What a tremendous honor this is. And hearing the stories of Judy really makes me wish I could have met her. I think I would have really got along with her. So thank you for this, and I will try to do my best to carry on the legacy.
Speak a little louder.
Oh.
Those at home.
Okay,
Thank you.
sorry. I would also like to thank my dissertation committee, Dr. Zoe McLaren, the chair that you've already met. Thank you for that nice introduction. And I want to punctuate a point that Jim mentioned about the faculty here at UMBC, how great they are. Such a true statement. You know, I work a full-time job, getting a PhD, not so easy. And I tell you, if it wasn't for the faculty here, the support I got, there's no way it could have happened. So I really owe them all for being in the position I am now. So thank you all. Of course, I have to thank my wife, Tammy Boward, who joined us here. She has put up with so much. She's helped me. She's taken burden off me so I can just focus on school and work. When this is done, we've decided we're going to get away somewhere. It seems like 4 years we haven't seen each other. Yeah. We send pictures back and forth so we remember what each other look like. And my parents, who I believe have joined us on this WebEx, Dean and Dorothy Boward, thank you for instilling in me early on the discipline that allowed me to get here as well. So thank you very much for that. So moving on to the topic, and actually before I dive into this, I feel there's a question on everyone's mind that may take us away from focusing on this. Tell us about the Scooper Bowl. When is it?
In May, in Boston. Yeah.
Okay, so
Like
every May.
graduation. I don't know if it's annual. Maybe in Boston people that would.
It
know.
is, it's held in Government Center, which
Okay.
is like the main. And Ben & Jerry's always comes and they sponsor it, and it's just like free ice cream.
All right, good
We
stuff.
know when our trip is. Where? All right. So the topic of my dissertation and presentation today is there positive spillover on quality of care from the Medicare Advantage program on traditional Medicare? So quite a mouthful here. And first off, I want to give just a general background, somewhat high level between the traditional Medicare and the Medicare Advantage program. Please bear with me on these details. I'm trying not to dive into the weeds, but it's really important to have at least a high level understanding of these two programs, understand the differences and how we could see some spillover and why it would even exist. So first off, with the Medicare Advantage program, what the government has done is essentially decided to contract with private insurers. So these are your Aetna, your Blue Cross Blue Shield, Cigna, United Health Group, to take over the administrative overhead and burden of Medicare. So with the traditional Medicare, often called fee-for-service, the government just handles administrative aspects, billing, claims, etc. And for this program, they said, hey, what if we work with some of these commercial entities, since that's what they do. If an individual that's in Medicare decides to enroll in one of these, they have the choice of either going to traditional Medicare or Medicare Advantage. A few things are guaranteed. The government certainly watches these organizations. They don't have a free rein. So at minimum, the Medicare Advantage plans, there's the Cigna, Blue Cross, they have to cover the same benefits that the enrollee would have received if they were in traditional Medicare. And we'll go on in just a few slides a bit more about that. In fact, just one slide. So not only are they guaranteed the minimum benefit that you would have received in traditional Medicare, but the Medicare Advantage plans have the option to provide additional benefits. A good example of this is gym membership or vision, dental. These can be draws for people to join these if they're very important to them. In a lot of cases, the person enrolling in it will have to pay a bit more for them, but it is an option there. Now, I already hit on some of these points, but what was the primary objective of Medicare Advantage back when it was originally stood up? And if you're familiar with Medicare Advantage or just Medicare, you know this has gone through several iterations. So what I'm really focused on is the way it stands now. And the primary objectives, there are really two of them. The first is they wanted to increase coverage choices. You know, just as I mentioned a few moments ago, when someone comes into one of these Medicare Advantage plans, they have the minimum benefits, but they can have additional benefits. And because in theory, there are many organizations participating in this, the individual has options. Different plans will have different setups. Maybe one has gym membership, another has dental. So there's more options as well as hopefully more comprehensive care as well. And for that one, maybe a good example is the dental, as a lot of people have teeth and want to take care of them. Another primary objective is to reduce costs. And the logic behind this was, hey, these big commercial entities or firms, this is really what they do. They have the infrastructure set up, the provider networks. So hopefully if we have them oversee the administrative aspects and the benefit coverage, they can leverage their infrastructure and actually lower the total cost. And we'll be looking a little more at that, just a little bit. All right. So this slide does a little compare and contrast. This is looking a little more on the financial aspect, primarily from the federal government perspective. So under the traditional Medicare, as I mentioned, it is administered by CMS, that's the Center for Medicare and Medicaid Services. They're the federal agency that administers Medicare. CMS pays for all the covered benefits. That is regulated, so it is well defined what benefits are covered. And through regulations, the payment amounts for different benefits, you go in for knee surgery, all of that is predetermined. There's no negotiation, despite what providers like to think. It is set, and they get pretty much cash on the barrelhead for that predefined amount for any of the treatments. So this whole fee-for-service concept, what this really means is when there are more services rendered, CMS pays more. So the more times you go in to see a physician or in a hospital, all things being equal, the more the government is going to pay. Switching over to Medicare Advantage, first of all, and this goes to trying to keep pricing lower, they have to compete. They have to compete with both each other, the Aetnas, the Crosses, as well as the fee-for-service program. So there needs to be a reason that an individual wants to join this specific program. For that, they have to come up with their hooks. Hopefully there are efficiencies that either improve quality of care, lower costs, whatever it takes to bring the individuals in. Now, the government has set up on the surface what is a pretty clever way of payment. These are referred to as capitated payments. And an example of this is they will negotiate with all of these managed care organizations, and there is a set price to cover everyone in a given county. An example, let's say if I'm an enrollee, and let's say I joined Blue Cross Blue Shield, and I'm making up numbers, but the government will negotiate and say, okay, for $100 a month, you're going to cover Mark. You have to ensure that he gets covered for the same benefits on traditional Medicare, and then anything else you offer, you negotiate with Mark on the price for that, but here's the $100 a month. Now, if it costs more than $100 a month for Blue Cross Blue Shield to cover me, that's a loss for them. If everything they can keep for total cost under $100, that's profit for them. So there's definitely incentive for them to keep that down. One addition to this, it is adjusted based on the health status because obviously sicker people cost more. And there's a predefined formula, as an example, if I have diabetes, Blue Cross Blue Shield may get $120 a month. But it's just a slight adjustment and it's that amount for every month. What this means from the plan perspective is like the Blue Cross Blue Shield, sicker people cost more, they know that. But from the government's perspective, yes, we're paying a little bit more per month, but there's that cap on it. So if Mark has to see a physician 50 times or 100 times, it's still that $120 we give. And one final aspect on the capitated payment, this is fundamental. This is a legislation around the capitated payments. And that is Congress mandated that the Medicare Advantage plans must receive on average the equivalent of what it costs for the same enrollee to be in traditional Medicare. An example that is often used is, let's say I'm a twin, we're identical in every way. Whatever my twin, or let's say my twin enrolls in traditional Medicare, I'm in Medicare Advantage. Whatever it costs to cover my twin in traditional Medicare, that is what government should be paying the Medicare Advantage plan to cover me. And the whole concept is they're forcing them to find ways to improve coverage of care, lower costs. And because I have options, by lowering costs, they're hoping that the plan won't adversely hurt my health or stop me from receiving needed procedures, because in theory, I can go elsewhere if I'm not comfortable with it. Ah, there it goes. Sorry, slight lag. I'm a visual person, and this slide just visually depicts as kind of a recap here. On the left, we have the traditional Medicare. And as you see, the enrollees, they do pay the government some premiums. It's a monthly premium. The government collects that. And then when the individual has services, ambulance trip, sees the physician or hospital, the government will pay the entities based on that set amount. And also the individuals, as you see, may need to pay a little bit for co-pays. Just as we said a moment ago, CMS, same thing, receives some money from the enrollees, and they send out to the HMO or managed care organizations that agree on capitated amount. And at that point, it's up to the enrollee and the managed care organization to cover all the agreed upon benefits. Now, background over, to get to the good stuff, the research question. Again, is there positive spillover on quality of care from Medicare Advantage programs on traditional? So is just the existence and the way that the managed care program works, is that actually helping those individuals that are in traditional Medicare, or my fictitious twin that I was just mentioning? Great guy though. Well, the first and primary question is, how can spillover happen? You know, these are two distinct programs. They're bifurcated, really. So how would there be interaction with them? So let's first take a look at the spillover pathway. Sorry, slight delay here, so. So it starts with the Medicare Advantage plans. Again, we talked that they're financially at risk. They really need to find ways to bring in individuals and theoretically ways to cut costs. Well, as they build out or find these ways to get efficiencies in their product, the healthcare coverage, those that do a better job at it can theoretically bring in more individuals. Remember, they compete, so they get more bennies to come in to their program. Kind of a volume game at that point. The more they get in, the more money. And what this means is the more bennies you get, hopefully then the more providers, and it can snowball at that point. Why market share is important is once you get past a certain point of market power, you can actually start controlling the market. That's where the spillover comes in. What you see in red, this is simply stating how I'm handling researching these different aspects of the spillover pathway. When it comes to the first two, it's supported via literature review. And the final aspect, the actual spillover measurement, that is done by empirical work. So we hit on this a little bit, but to recap a few points and bring up, I think, one or two new ones. First thing is, how can competition increase efficiencies? Well, as we all probably know, managed care organizations have a number of levers that they use to try to, first of all, control cost and even help with the quality. A great example of this is the gatekeeper aspect. So a lot of managed care organizations, depending how it's structured, will require you to go see a primary care physician before seeing a specialist. So what they found in fee-for-service environments is a lot of times patients will just go on a fishing expedition. If they don't receive the services that they wanted, can't blame them. They start going elsewhere and seeing specialists at a high cost. The theory with the gatekeeper is hopefully if the primary care physician treat them, the primary care physician will know which specialty the individual to go to and hopefully guide and actually help monitor the patient throughout the process. Another example is managed care organizations can influence the adoption of technology. How is that? Well, if a managed care organization realizes that MRIs are not the best technology for peeking under the skin, they might stop paying for MRIs. And if they get enough of the market power, hospitals or other entities that have MRIs might stop getting new ones and substitute them for whatever technology the managed care organizations are paying for. And all of this hopefully can lead to lower health prices. So the second big question here is, how can market share influence spillover? Well, the first thing is we need to go from that market power, and we see that if they have more efficiencies, hopefully they can bring in more beneficiaries into the program. Once they have more beneficiaries in there, they, well, first of all, that gives them market power, but then hopefully from that, they can get more providers. Now, this is the interesting aspect of it, and that is providers who see individuals with managed care organizations, especially Medicare Advantage patients, they tend to get less per visit from individuals. So how can a managed care organization come in and say, hey, please take our patients, we're going to guarantee you less per individual per visit? Well, this actually works because they'll give them a lump sum. They'll say, we're going to give you so much per year to take on so many patients. So again, it's a bit of a volume game. They know some patients they see aren't going to come in that much. The ideal patient for this situation is one that doesn't come in at all. So they know they're going to make profit on some and lose money on others. But as a Medicare Advantage plan gets more and more enrollees, they can promise a more stable base for the providers and entice them to come into their network. And this all really boils down to the key point here is of the mixture of patients. Many studies have shown that the behavior of the providers or hospitals actually changes based on the primary mix of patients. So if they have a higher ratio of Medicare Advantage plan enrollees or managed care organizations coming in, they will actually adopt the routines and procedures of that site to maximize the patients from those managed care organizations. Another example here is diabetes care. For fee-for-service, remember the physician provider gets paid every time you see them. So there's the reason for the provider to want to see them routinely. That might always not be necessary for it. So in this case, the physician will set up intervals much wider, and hopefully they'll keep the health of the patient in mind, not adversely affect them. And if they have that structure in their organization, having those longer intervals, they will more than likely apply it to the fee-for-service individuals, because it can be somewhat challenging having different approaches. So why look at this spillover? Sorry, there's a lag here. So first off, there is differences in the population and program for comparing these two. And again, this is why we're looking at the spillover aspect and not the direct cost. We also know population differences. Certain type of individuals tend to favor one program over the other, and there are cost differences. We also know that cross-sectional analyses, and a lot of them has been done to compare traditional Medicare and Medicare Advantage, tend to just look at cross-section of care and not longitudinally. And as far as what my study is really focused in on, any spillover from the MA program on traditional Medicare, well, that's really a benefit for the traditional Medicare enrollees and should be considered. Now we're running short on time. Hit on a few things here. As I mentioned, there are differences in population and program costs. It's difficult to compare in some sense. This is an example of quite a few studies that when you just do more the accountant approach of looking at the cost, they find that the government is paying more for Medicare Advantage than traditional Medicare. This specific study by MedPAC finds it's about 3% higher. And why this is important is you have to recall one of the primary objectives was to reduce costs with the Medicare Advantage plan. So a little bit of an oops and a red flag here, but I think there's more to the story. They've also seen that there are population differences. So they found low income individuals. There's actually about 15% more in Medicare Advantage than traditional, and they cost more to cover, and they tend to require more services than the non-low income. Another key aspect when comparing just the direct cost is these studies look at cross-sectional analyses. So at any given point in time, we see, yes, it could be just the direct accountant approach finds that it's 3% higher. But another very interesting point that many studies have found is Medicare Advantage plans tend to spend more on preventative care. So what this means is, in the long run, it could be cheaper. And these individuals that are in Medicare Advantage plans may cost less over the course of their life if they stay in the Medicare Advantage plan. And again, what we're really focused in on is the aspect of if there is spillover, we have to credit that on the Medicare Advantage plan if it's positive. So why now? This is a question because if you do research or study in this area, you've probably seen there's been a lot of research studies that look at fee-for-service, and they generally will go on HMOs, a type of managed care organization. It's how it's structured and controlled. There's no lack of these types of studies, but there's very, very few studies that have actually looked post-2010. And why this is important is the government stood up a new center within Medicare that is called the Center for Medicare and Medicaid Innovations, or Innovation Center. And the whole focus of this entity is to test models, try to come up with ways to improve the quality of care and reduce costs on the traditional Medicare side. So this can definitely change the health status on the traditional Medicare side. I think it's really important to be looking post CMI. Another important reason is Medicare Advantage enrollees continue to increase. Actually, right before, when the Affordable Care Act was originally passed, GIO and a number of researchers looked at it and said, okay, this is the debt to Medicare Advantage. We're going to be seeing fewer and fewer, but we're actually seeing the opposite of it. And another aspect is most of the studies that I mentioned looked at a specific type of plan. Yeah. I hope to look at a broader spectrum. I already mentioned about the CMMI and their focus, as I said, is to try to find ways to improve quality of care for the traditional Medicare's enrollees. The key point here is depending on the outcome of these models that they stand up, it could certainly bias results. So we have to be very mindful of this. We don't attribute results from one of these models to Medicare organizations. One, I don't want to call this good. For the model standpoint, it's a little simpler, but to date, only 4 of the 54 models as CMMI has stood up has met the criteria of improving quality or lower cost. So it's still something I'm very mindful of. But I think as they are standing up more and more models, hopefully they'll have better outcomes, and it'll be more important as hope to continue this research. As I mentioned, enrollment in Medicare Advantage continues to climb. Here in 2010, we see it was around 25% or so. And in 2022, we're almost at 50% at that tipping point. So prognosticators were off on that one. There is certainly something in Medicare Advantage that the enrollees enjoy. Okay. So do the efficiencies you mentioned have that spillover? What this would show is positive spillover, demonstrate a social benefit for the fee-for-service individuals, which yes, a amount sure could be estimated for that benefit, but it is certainly a qualitative aspect that we have to keep in mind. Positive spillover, if it can be identified, I think would be really useful for CMS, especially given what I just mentioned with CMMI that they stood up. Hopefully they could work with plans and determine whether or not if they share any of the proprietary information, and whether or not anything would be useful on the fee-for-service side. So hopefully could get the two groups working together. All right, moving on to the measuring of the spillover. The dependent variable that I'm using is the number of potentially avoidable hospital admissions. And this is just the rate for the traditional Medicare venues. Because remember, we're looking at spillover, so I think there will be a positive spillover. That's why I want to look at only the traditional to see how that rate changes as they get more market power. The reason I selected this is that it includes conditions that are commonly observed in Medicare enrollees. So I think it represents a reasonable portion of the total Medicare populations. Many of the conditions can be controlled with proper care. An example of this is leg amputation with diabetes. My understanding is if diabetes is properly maintained, the probability of having a leg amputation is very, very low. And so this is one of the things I'm looking at, and why this is important is because I feel that spillover could be directly through the providers like I talked about, but can also influence the behavior by working with the providers kind of through the, with that preventative care aspect. How it is calculated, this is actually 12 different diagnoses. It's a index. It is created by ARC, so it's an industry standard, a PQI specifically. It's used by the industry quite a bit. Medicare uses this for several of their evaluation and when looking at various models and outcomes. It's reported, it's a rate, it's reported per 100,000 individuals. Mention that. And lastly, the time frame. I'm looking at a longitudinal model. Based on the data, the time may expand a little bit. Right now, and I'm using all publicly available data for this, so I'm really at the mercy of that and what CMS puts out. Right now, I have data for 2012 to 2018, that time frame. And my unit of analysis, I'm looking at it a couple ways. The primary is county, and the reason being is when the managed care organizations, Blue Cross Blue Shield, when they contract with government to cover individuals, it's actually at a county by county basis. So every county, there's really a different bid. in negotiation. And then I'm looking at hospital service area, is there are some needs to look at a hospital level, but county's the primary. Now, the policy-specific explanatory variable, remember I mentioned spillover is really controlled by that market share or market. I'm looking at what is commonly referred to as Medicare Advantage penetration rate. I didn't make the term up. I'm just rolling with it. And what this is really just the rate of all individuals that are eligible to be in Medicare, what percent, if you will, are in Medicare Advantage. And so the higher the number gets, in theory, the more market power just in the Medicare population that Medicare Advantage has. Now to geek out for just a moment or two here, is the model that I'll be using, and my apologies, some things have dropped off on the model, but overall, see here the policy, important variable, that penetration, and the dependent is that avoidable hospital admission rate. My theory is that as penetration increases, that is, they get more market power because there is a higher percentage of Medicare Advantage individuals, the rate of avoidable hospital admissions will go down. And you see two in red here that I'll hit on in just a little bit. Data with this, as we all know, working on these studies, it's only as good as the data. Things that are really important in this study is, of course, that the population health is affected by many more factors than just Medicare Advantage plans. Very important because I need to control for the different subpopulations and the different influences on individuals' health to ensure that what I attribute to the managed care organization is actually the effect that they had and not overestimate the other factors that cause an improvement. And all my control or explanatory variables are driven by literature theory. The categories, I'm gonna have to go into those. One aspect though is the quality of care. So you would think you have hospitals in a certain county are higher quality of care, or outpatient or professional services have a higher quality of care. That itself is going to help the health status of the individuals. Well, this actually poses a conundrum, because the big question is, well, are Medicare Advantage plans influencing the quality of the hospital and the professional settings, which case we attribute it to them, right? But if it's unrelated to Medicare Advantage plans and they just happen to get more enrollees in that county, then we're going to bias the results. So this is something that I'm looking at independently to try to look at the relationship of the quality of care in the area and the relationship to the Medicare Advantage penetration. An issue I'm dealing with is omitted variable, the bias. Biasing the results. Sorry, slight lag here. Okay. And the key is that the actual firm's decision to go into a county or market is proprietary. We don't understand why they're going in. Are they cherry picking? Is there other attributes that is affecting the health outcome of individuals and they're aware of this and they're following suit? We don't know. Also, the beneficiary's decision, because not only does a Medicare Advantage plan have to decide to go into a county, but there's that decision by the beneficiary whether or not they are going to join the plan. So these two elements are unknown, and if not dealt with, are certainly going to bias the results of this. And there. The key is that I plan on using an approach two-stage square using an instrumental variable. This is also driven by literature. What I'm using is the county rate, which is essentially the amount that traditional Medicare pays for the average individual in a county. And that is what Medicare Advantage plans, when they come in, that's how much they're going to get for their covered average individual. Yeah, I have not yet applied that, but we'll be doing so very soon to control for those, at least lower the bias. Now, all right. And I wanted to give, I haven't been able to run the results with all the data that I want. I'm still collecting data on it. I did run some analyses with some censored data. And by that, I mean there was publicly available data that unfortunately didn't cover all the counties needed. So this whole slide is basically a big disclaimer about what I'm going to show you is not necessarily reliable, but there are a few interesting things that I wanted to point out. First thing is I did a quick analysis just looking at the MA penetration rate and the avoidable hospital admission rate. And on the horizontal here, we have the MA penetration rate. So like here would be 20%, 60%. And vertical is the rate of avoidable hospital admissions. So lower is better. And what we see in like 2012, there's slight decline. So as MA penetration increases, we're seeing a decrease in the rate of avoidable hospital admissions. What's interesting with this, and again, this is just looking at the two variables, no controls in it. We get to 2017 and it seems to really flatten out. So this could be effect of CMMI, some of their models, but it's something I am looking into. All right, so key findings. I ran model with the censored data a couple ways. One is more the traditional OLS, just pooled data. And what I found was very, very consistent with what the literature has. And that is really what I was expecting. And when MA penetration increases, we do see a decrease in avoidable hospital admissions, meaning there is a positive spillover. But when I run it with first difference to try to control or deal with some of the known issues with the data, it actually flips. I was not expecting this. Again, censored data, I'm not claiming this is reliable, but it definitely caught my attention and something I will be looking into more. As I mentioned, there have been a lot of studies around this. Most of them do not apply the model I did to get that, what essentially says a negative spillover effect. So I will be focusing on that as I continue my research. And go through the recap here. I've been talking about it for a while. I'll just shoot to the question and answers.
Great, thank you so much. Well, actually, first of all, I think I've mentioned this to you before, but my dissertation work was also comparing HMOs and traditional fee-for-service.
Okay.
And I as well did a two-stage model and instrument to try to figure out some of these selection issues. So I'm really interested in kind of seeing what the findings you get from this study of a more recent version related to like managed care. So with that, we have time for a question or two from anyone in the audience.
Hi, I'm Stephanie Harshman. So, yes, when you're talking about hospitalizations, are you taking into account like rehospitalizations within 30 days, or are you only just looking at hospitalizations in general under those diagnoses groups?
It is just looking at the hospitalization. It's not necessarily looking at that readmit.
Okay.
I'm gonna have to go look back at the methodology by art, but I believe it excludes the readmits.
Because I think that would be interesting if you have people with your traditional Medicare A and then your people with your managed care, and their discharge disposition from a hospitalization is, say, like skilled nursing or something to that effect. And like what we see in my line of work, because I do work with a lot of managed care products, is there's these shorter length of stays for your managed cares versus your traditional Medicare A's. And then is that rehospitalization then creating more issues within, the quality of care aspect, right? So I was curious about that, if you were keeping that in mind.
No, I'd love to. That is a fantastic point. Unfortunately, with this study, I'm limited to public use data. I will say, I do a lot of work for CMS. I'm a contractor, and it's frustrating because theoretically, I have the data, but I cannot use it for this. But yeah, if I'm trying to negotiate with them, probably when I complete this, but I'd love to look at, the episode of care when I can get the claim level data to see what's going on there.
Yeah.
Great. Other questions?
I have one. Do you do any screening for like mental and nervous? Because it's a very high cost thing. And if you were to have a relationship with a physician or somebody for a long period of time, but the Medicare Advantage plans that doctor doesn't belong to that. You're not gonna move. Or does the Medicare Advantage plan not provide or allow, you know what I'm saying? They structure their plan so it's not as easy for me to be able to access those people that I would usually do if it's just regular fee for service deal.
Right. So as far as like specialty goes, Medicare does require certain types of coverage. One of the problem points is like with rural communities, but that applies to either side.
Yeah.
So in theory, they should have coverage of various specialties. When it comes to, you mentioned sometimes you build relationships with certain providers. And this is really important, really that market share aspect, because the managed care organizations completely understand this. People need their relationships and they want to stay with providers. So as they can get more enrollees, they have more leverage to negotiate with providers. And hopefully, as they get a larger and larger network of providers, there's a higher probability that the people that may enroll will look at the list of providers and see the one that they have a relationship with. But that whole aspect of the relationship is something that the managed care organization are very aware of and try to deal with enticing individuals. Yes.
So you showed us a table for your OLS like regression and I was just wondering what kind of data, since you are still looking into like data set to run, what kind of data did you run for that? Was it based on what counties did you use for that?
I'm sorry, can you say the last part again?
So what kind of data, the data you used to run that kind of like regression to get that results? Where was that data coming from?
I used several sources. Dartmouth Atlas was very helpful. Medicare itself is doing better with their data sharing. They stood up a new site. I should know this like the back of my hand, data.cms. I've forgotten what it is. But you can get a fair amount of data on that. It's certainly the availability of public use files isn't what I would ideally want, but honestly, I think CMS as a whole has done a really good job in making more and more information publicly available because they know, when they make it available, people can do more research, hopefully provide useful information as they administer the program. But yeah, Dartmouth, I use some from Census, and CMS would probably be the primary source.
And so it means that the data you're going to use for the analysis is going to be like a representative something that is it like a representative sample that you're going to use in terms of generalizability?
Yes, most of the data that I'm pulling from is actually population. There are some that is a sample, and that tends to be more when they do like expected counts, the expected number of ED visits. That is sample based. But ballparking it, I would say 90% of my data or so is population. And we can talk afterwards. If I get your name, I'd be more than happy to email you the data sets and sources that I've been using.
Great. Well, I'm going to thank everyone again for attending, and I would especially like to thank Mary and the Shinogle family for establishing this fellowship for us and being able to support students like Mark who are moving through our program. There's information on our website if you haven't seen it about the Shinogle Fellowship. We have links to all the prior recipients, and Mark will be up there soon, and you can see their presentations and things that they're working on as well. We're always interested in further kind of supporting this fellowship that supports students doing work that's related to the work that Judy did. With that, let me say we do have some refreshments outside, so we can continue a discussion outside with refreshments. And thank you again, everyone, for attending.